webinar of European Endometriosis League. So I'm Horace Roman from France, and I am the moderator. So I will take your questions, and then I will forward them to Gernot, which is the speaker today. So it is my absolute pleasure to introduce him. Don Gernot Hudelist is a well-known, very skilled surgeon in deep endometriosis, in colorectal endometriosis in Austria. And he has a huge experience in this kind of surgery. So it is the right person to speak you about the management of complications related to deep endometriosis surgery. So Gernot, please tell us everything you think it's important to know about the complications when someone wants to carry out the surgery of deep endometriosis.
Yeah, good evening, and thanks for everyone for joining in. Do you hear me?
Yes, we
Excellent.
hear you very well.
So I've been asked to give this presentation for, I think, the third time, and I'm wondering, probably I'm asked because people think I've got so many complications that the guy should be able to tell us about complications. So basically, I'm happy to say that we are in the lower range, but I personally think that this issue is highly interesting because it's very individual, and it needs good interdisciplinary work and experience to manage complications well. And nobody really likes to talk about it in extent. And I think that it probably should give us a thought, because we're all into surgery and into dealing with these patients, and sooner or later we will have a problem. So my aim is to give you an overview of the things that may happen. And if we talk about surgery for deep endometriosis, we're talking about colorectal surgery, we're talking about urological surgery, partial cystectomies, urethrolysis, urethral neoimplantation, etc. Pelvic surgery, that of course may cause problems. And I think we also between a complication, which is defined as any deviation from a normal postoperative course, and a sequelae. And the sequel is an after effect of surgery that is inherent to the procedure. So I'm more going to focus on complications, but I'll also spread a few words on sequelae. So in the ideal scenario, we should all be able to talk the same language. And talking about classification and prevalence of complications, I think it is of utmost importance to focus on one common classification, and that's the Claven-Lindo classification. And as you can see, and as you all know, the complications that may arise and that are known as major complications are grade 3 complications requiring surgical, endoscopic, or radiological reintervention. And these are the complications which will also increase morbidity and which will also cause harm to the patient, probably. And as you can see, we as pelvic surgeons are dealing with an area that is quite prone to cause problems. And these are data from colorectal cancer surgery demonstrating that, especially in patients with low rectal resections, either it's shaving full thickness, segmental resections, leak rates are significantly higher the lower you get. So we are dealing with basically young patients. We are dealing with infertility patients, pain patients, and there are two meta-analyses that I would like to show to you. And it's great that Horace is going to moderating this session, because he has provided us with probably the largest body of evidence on this issue. And as you can see, data on patients undergoing bowel surgery for deep endometriosis show that the major complication rates range between 2 to 8%. And we have to expect a rectovaginal fistula rate of about 2 to 4% and a leakage rate around 2 to 4% in general. But however, and these are data from Horace's group, recent data, there is a big variance also regarding additional risk factors. So at first sight, you can again see that RV fistula rates, leakage rates range around 2%. 17,000 patients undergoing bowel surgery for deep endometriosis, half of them shaving, half or a quarter of them disc resections, and 36% segmental resections. So it is quite rare, but if it happens, it is a significant problem. And the question is, can we just state that a certain technique is inherent to a certain complication? And I think looking at these data, we have to bear in mind that there are additional risk factors that contribute to complications in colorectal surgery for deep endometriosis. So what are these risk factors? And the first question is there a better technique? And well, no, apart from age, smoking, and opening of the vagina, could we state that shaving or disc resection or segmental resection is more or less safe than the other one? And does it make sense to increase the load of protective ileostomies and dividing stomas? And the only prospective randomized trial so far is deriving from Horace, who has compared conservative patients, which means conservative surgery for thickness resections, with segmental resections. And they have not been able to find a significant difference regarding major complication rates. However, the authors showed that the rate of bowel stenosis might be higher in the segmental resection group compared to the conservative surgery group, with no differences in sequelae such as LAS score. So these are our data. Again, 140 patients. We predominantly do nerve vessel sparing segmental resections, but again, in these two groups, disc versus segmental resections, we have not been able to find any significant differences in complication rates. So we ask ourselves, talking with Attila Bocker and Horace, whether it would be a difference if we look at very, very low resections, below 7 centimeters from the anal verge. And again, you can see we have not been able to find a difference in LAR scores comparing nerve vessel sparing segmental resection techniques with the full thickness transanal conservative approach, with a possible, but however, a retrospective data, slightly higher complication rate in the conservative group. But again, retrospective data from a very, very selective patient cohort. So finally, and I want to go back to Sofiane Benefalon's systematic review. I think we have to bear in mind that comparing techniques is difficult because it also is influenced by the height of the anastomotic line. However, it appears that shaving may confer slightly lower complications regarding fistula and leakage compared to disc resection, with no significant difference regarding leak rates between shaving and segmental, or between disc resection and segmental resection. However, these data do not clearly take into account additional risk factors and look primarily at the outcome of the technique as such. So what are risk factors, or does it make sense to prevent these problems with the diverting stoma? And again, the only valuable guideline published in 2016 again states that the use of a diverting stoma may reduce adverse consequences of anastomotic leakage, which is important, but it does not appear to reduce the likelihood of a leakage per se. So what are risk factors? And as I showed before, it really makes a difference whether you are performing a low or a high anastomosis if you are performing full thickness surgeries. And large data from colorectal cancer surgery again demonstrate that low or ultra low anastomotic lines lead to a tripling of leakage rates compared to patients with anastomotic lines above centimeters. And this is a small but interesting paper from our department of general surgery. It also may make a difference how many stapling magazines you will use if you do segmental resections. So the more stapling magazines you use, especially 3 or more, will, and these are data from colorectal cancer patients, but they may be applicable also to endometriosis patients to a certain extent. The more magazines you use and the more intersection lines you get, the higher is the likelihood of a leakage rate. And you can see that this is a rectoscopic view of a patient with a leakage. And the authors suggest that leakages may predominantly rise at the area of the intersection of the stapling clamps by using more magazines. So coming back to risk factors, finally, we are performing a handcraft. And I think with every kind of work you do manually, you will get safer and more experienced the more often you're exposed to a certain task. And we know from gynecologic oncology and from guidelines that there is a difference in outcomes, especially if you look at ovarian cancer surgery, whether patients are treated in low volume versus high volume centers. And I think that this work is shown, should be shown more often. And it's again from Horace's group, who looked at centers in France and different volumes, numbers of procedures per center and per year, and also at the caseload per surgeon. And what was quite evident is that that centers with a load of more than 40 procedures per year have significantly lower problems compared to centers with fewer than 10 procedures. And the possible optimal cut-off value for a surgeon may range at least above 13 cases per year. So it again shows that you need to have a regular exposition to certain complicated procedures. You need to have your interdisciplinary team in shape to have reach a complication rate that is acceptable. And we looked at this is a preliminary data from the German group and Austrian and Swiss group. And again, we also noted in our first analysis that centers with few procedures may have more complications. So finally, what is the consequence? And I think it's about stratification of risk factors. It's about early recognition, and it's also about possible prevention measures. And I'd like to show you that it is possible to estimate the height of the anastomosis in patients who are scheduled for colorectal surgery for deep endometriosis with transvaginal sonography. This is a work published by my ex-fellow from Oslo, Christina Eng, and we are able to demonstrate that by estimating or measuring the height of the lesion to the anal verge, we are also able to estimate or accurately estimate the height of the anastomosis, thereby again stratifying patients into high-risk patients, low anastomotic lines, higher leak rates compared to patients with higher nodulus and possibly lower leak rates due to high anastomosis. And finally, we have a tool at our hand, and the updated version of the ancient classification has been published recently, where we're able to use a pre- and intraoperative classification system for endometriosis that has already shown that it does not only correlate to the type and intensity of pain symptoms, but also applying the ancient system, we are able to estimate operating times. We are able to estimate the rate of possible complications by the extent of the C compartment affection. And Sarah Imboden's group has recently shown that if we have patients with compartment B disease, there may be also high risk of postoperative voiding dysfunction, etc. So preoperative staging using sonography or MRI using the #ancient classification may help to stratify patients into low-risk surgical cases and high-risk surgical cases. Again, work that we got accepted last week, again demonstrating that this can actually be done with transvaginal sonography and also with MRI. Secondly, I would like to talk about early recognition, and again data from colorectal cancer patients regarding septic complications caused by leaks demonstrate that a standardized follow-up of patients undergoing major pelvic surgical procedures, taking into account clinical parameters, we all know, fever, heart rate, respiratory rate, etc., will help to detect sick patients early, with a significant difference in morbidity the earlier you will intervene and or re-intervene. And this is, again, Horace is so predominantly publishing work on these issues that it causes some kind of complex by the time. However, this is another paper by Horace's group, and they looked at the value of CRP, which we all have at our hand, and found that that a cutoff value of 100 milligrams per liter on day 4 does have a very good negative predictive value. So if you've got a patient who is below 100 mils on day 4, she's very unlikely to have a major problem, pelvic abscess or leakage. And we did a similar thing. We just have been a bit slower. And these are data from my group. And you can see we looked at 183 patients undergoing colorectal surgery for deep endometriosis. And we have been able to reconfirm that 100 milligrams per liter is the ideal cutoff value, with a positive predictive value, quite low, 30%, but a high negative predictive value. So if you get these patients below 100 on day 4, it's very unlikely that they will have a leakage. However, these data did only apply to patients with an anastomotic leak. We had 2 patients with fistula And one of these two did not show any deviation, as you can see in the yellow line. And we also have not been able to confirm that a decrease as such on day 1 to 3 is specific. So in our series, we observed an increase even on day 3 and then up 4. But again, I think finally stating it does give you a clue to look at the CRB on day 4, whether you're in a safe area or not, of course, taking into account the clinical state of the patient. So what do we do if we suspect a problem? If we do have a patient that is not doing well, who is just simply stating sick, and the first measurement would probably be a CT scan. We would do a CT scan and do a late series if we suspect urethral leakage, which has been demonstrated quite specific. But what about suspected anastomotic leaks? And again, I think this is a work I would like to show to you. The negative predictive value is only 0.8. So you will get 1 out of 10 patients who will have a negative CT scan, but will have a leak. And it does not completely rule out leakage if you do have a negative computer tomography done with a contrast media. And again, if you stick to these findings, and again, data from colorectal cancer patients, you will have a significant increase in morbidity and possibly also mortality. So we do have radiological measures at our hand, but they are not 100% accurate. And I think that should be kept in mind. So what can we do to finally prevent complications? And I would like, again, to show you that it may make sense to do a selective decontamination of the digestive tract, which means yeah. So there is some issue now. Sorry. Do you hear me, Horace? Okay, for some reason I can't hear you, but anyways. So
I cut the sound in order to avoid any noise.
Okay,
You
so
can
I think, yeah, basically, that's the end. I would like to thank you. And again, we learn every day. Thank you very much for listening. You there, Horace?
Yeah, but yeah, I'm here, but I need the permission to open my microphone.
Oh, okay.
So I received. So excellent. Thank you very much. We did not hear your slide 34. Could you please repeat it, because the sound was cut?
Okay, hang on.
34 and 35.
34 and 35. Hang on.
Yeah. The two last slides.
Yeah, that's it.
Yeah, yes.
Yeah, I mean, yeah, sorry. I think the question is, how can we, what I would wanted to state, prevent complication? And I think there is some good evidence saying that selective decontamination of the digestive tract does make sense. We got this data from colorectal cancer patients with oral aminoglycosides 24 hours pre-surgically. But finally, the data so far, and in my experience, says that it may not be the issue of a certain technique that is always going to be safer, because we're confronted with a disease that is very variable. I think it is about stratifying patients into high-risk patients and low-risk patients, into high anastomotic and low anastomotic patients, into complex and less complex surgeries. It's about standardized surveillance, and I think it is about treating the right patient at the right time by a team that has got a relevant, a sufficient caseload. Yeah, thank you very much.
Thank you very much. It was very complete. And we have some questions. So I have just a question or a remark. So about the number of stapler magazines. Do you think that the number of stapler magazines is somehow linked to the height of the anastomosis? Because when I cut the rectum, when the lesion is 10, 12, 15 centimeter high, you need one magazine 65 millimeter and you cut. While if you are very low on the rectum, you cannot slip inside the pelvis, and you use, in this case, the rectum is very large, so you can use free cartridges, free magazines.
Yes.
So I think it is somehow.
Yeah, I absolutely agree. Again, these are data from colorectal cancer patients, but I just flipped up the chart again. The authors demonstrated that it is a factor that is independent of the height. So of course you may have to use more magazines if you're doing segmental resections, the lower you get, I fully agree, but it is not the only factor. In the paper I've shown, it has been an independent factor. It's not been confounded by the height.
Yeah, it sounds, it makes sense, because when you use several magazines, the lines, the stapler lines cross. They are not continuous. They cross, so you may have some some kinds of tissue which may undergo necrosis. So we have another question. Tanner asks if we use if you recommend what do you recommend to prevent adhesion formation after the surgery of deep endometriosis, of colorectal endometriosis, and when you use, if you use, and when you use the anti-adhesion agents?
I personally only do resorbable ovarial PEXIs, which has, I think, a quite good body of evidence to make sense. Anti-adhesive agents, I think there's some good data for hyaluronic acid, but to my best knowledge, the two papers who have used the hyaluronic acid have been derived from the same group, and that has some criticism. We do not use it on a general basis. We stopped using, I can't remember the name, it's some powdery stuff, because reports on increased infection rates. So to answer the question, it's a simpler variable PEXI with an absorbable vicryl thread. Also based on the fact that regarding the fertility outcome, the mobility of the tuber ovarian unit may be the most crucial issue.
Yeah. Do you, yes, and I answered him by chat that there is a randomized trial, very nice randomized trial in 1,000 patients. I think the author is Brown, and I think it has been published in 2002, 2004 in Disease and Colorectal, and it demonstrates that the rate of fistula when you put anti-adhesion barrier around the stoma, the rate of fistula increases sixfold. It was huge. So I think, honestly, I think that we have enough data not to use anti-adhesion agents when you perform a suture on the rectum, because it is very, very, very likely, it has been demonstrated that the rate of fistula increases. Then a question from Avi Shalom from Israel. So he asked if you perform the hysterectomy in order to raise the chance of pain relief in patients managed for deep endometriosis.
To my best knowledge, there's some. It's difficult. The question is, I would, if I would do the procedure primarily for reduction of therapy-resistant pain, not responding to conservative measures. And obviously, we're not talking about fertility patients. Yes, I would lay my threshold very low to perform a hysterectomy, most likely a supracervical hysterectomy. Also because there's some data showing that the decrease in pain will be higher, especially in patients with adenomyosis. And we all know that about at least half of the patients with deep disease do also have adenomyosis.
Yes, that's what I answered. And in my experience, I saw another advantage to perform a hysterectomy. Then you can give a pill to the patient to avoid any recurrences on the ovary or elsewhere, and the patients will not bleed because I think that particularly in elderly women with adenomyosis, even though you give her a pill to avoid the recurrences, there is a lot of bleeding, and the patient is very likely to give up your pill because she has bleeding one day
On and off.
Yeah, and performing the hysterectomy avoids this bleeding, and I think it is also a measure to prevent the recurrences, because the patient can take the pill without being embarrassed by the metro age.
I'd like to give a question back to you, Horace.
Yeah.
There's always been some discussion that in patients who undergo hysterectomy plus colorectal surgeries, are you worried about the vaginal wall suture close to the stapling line, probably? And I think it may be worthwhile to preserve the cervix, but there is no good data. What is your thought on that? Maybe probably that would be interesting for the audience as well. Maybe you'd like to, yeah.
So if I have to perform a disc excision or a colorectal resection, if the patient has no vaginal infiltration, I prefer not to do the hysterectomy in order not to put a suture just in front of the rectal suture. If the patient has infiltration of the vagina, so you have to open the vagina, I think, in my opinion, it is better to perform a hysterectomy, because it is better to suture vagina against vagina than the vagina against cervix. So if you have to open the vagina, I think it's safer to carry out the hysterectomy if it is possible, and that's what I did today, this morning. It was this problem with a patient with 3 centimeter infiltration of the vagina, with a big nodule on the rectum, and she does not longer intend to have a child, and the uterus was adenomyotic. So I said that it is better to perform the hysterectomy and to close better the vagina, even though the suture is not very far. But I think that the suture is tied after the hysterectomy, while it is a bit more fragile when you perform the large excision of the vagina and you insert the vagina on the cervix. So this is my feeling.
I agree.
Then you have a question from Aysen. Where does he come? Aysen. I don't know where he comes from or she comes from. Where is the question? Say, do you prefer to inform patients preoperatively for the risk of leakage if their lesion are below 5 centimeters? So I think the answer is yes.
Yeah, so of course you have to.
You have to inform any patient, wherever is the lesion, that there is a risk of leakage if you perform a colorectal resection. Far from
I would always, of course, well, this is a legal issue, and I would always discuss the issue of protective ileostomy, even if we do not perform it on a large scale, because from my experience, you may get in a situation where you will then do it for some reason. So I would always talk about a protective ileostomy, even if the chance is very low.
And far from more, if I perform the surgery for endometriosis, and from while to while, despite all the preoperative assessment, I find lesion on the nodule on the rectum, or I do not remove it. I never perform a rectal suture if the patient has not been prevented. Because just imagine that the patient planned to go to Tahiti or Hawaii in vacation 1 month after your surgery, and you have a complication for perform a stoma. So we cannot afford, we do not know what the patient planned to do during the months after the surgery. So I think you cannot perform a rectal suture if you did not discuss this preoperatively. So I prefer to perform any other surgery. And then I said, I found a nodule, so we have to speak about, we have to perform a better preoperative assessment. We have to speak about complications. And then if you wish, if you agree, we'll perform the surgery, a second surgery. So I think it is safe and it is correct for the patient, because we can be very harmed just because we want to do all during the same procedure. Yeah, I have a question from Peter from Poland, and I like very much this question. He said, have you experienced complete closure of the intestinal lumen at the anastomosis site after segmental resection in your practice? Because he performed removal of an extensive rectovaginal endometriosis in a patient with double uterus, and he performed a stoma, and despite the stoma, the anastomosis was healed, but it was completely occluded. So I had this experience twice, and both patients were enrolled in randomized trials. So the randomized trial you presented, there were 2 patients with this kind of stenosis, and both patients had stoma. So I think that the stoma, we presented this data in a recent paper. The stoma may be related to the stenosis of the anastomosis. Maybe the stools play a role in keeping the anastomosis open. So what is your opinion about this?
Well, basically I don't know why, but I probably because I don't get all the patients to the follow-up, but bowel stenosis is a rare complication in our series. We had the work published in ACTA 2 years ago showed one bowel stenosis in about 1.2%. So it appears to be rare, but I also have to say that we lost 70 patients to follow-up in this group. So it might be higher. So it does happen, and it is more common, of course, compared to patients undergoing discrete resections. But I do not see the big problem behind it. Because even if you do have a patient with anastomotic stenosis, either you dilate it digitally or with a balloon, and it does not really confer a major reintervention. So from my point of view, it's not a big issue.
So when I was in Rouen, the stoma, the rate of stoma was higher than usual, because we were at maybe at 30% or even 60% in big rectovaginal endometriosis where the rectum and the vagina were open. So the colorectal surgeon in Rouen preferred to do this because they said that you deal better with the fistula if the stoma was placed prophylactically. We changed this strategy now in Bordeaux, but we could observe that the rate of stenosis in patients follow up closely was about 8%, and we published this this year in Journal of Minimal Invasive Gynecology. And in 24 patients with stenosis, we had to reoperate, I think, 4 or 5, because there was blotting, dyschezia, so they were not very comfortable. So we had to redo surgery to cut, to remove the anastomosis.
So, but may I ask you, so balloon dilatation had not been successful?
Yeah, it was not successful. 1 or 2 or 3 procedures.
Okay.
And I remember one patient where we could not find, and the patient had not stoma, so it was a patient without stoma. We could not find, the gastroenterologist could not find the lumen. He said, you closed the rectum. I said, the patient had the surgery 3 months ago. So if we had closed the rectum, I think we would have consequences. There is no occlusion for 3 months. And it was very, very difficult. And you can see, I think I added this movie to the paper in Journal of Minimal Invasive Gynecology. Is very, I was set up when I said this. So I don't know why in endometriosis it seems it's more frequent, the stenosis. And Marcello Ceccaroni published his experience. They found 6% in their series. So I think it should be
discussed. I agree. Yeah.
But it may happen. So Peter, it may happen. We had this. Taner Usta from Turkey asked if can we say that there is no space to preventive stoma? On the other side, colorectal surgeons believe this approach is #1 protective approach. It is very difficult. So please answer these questions, Gernot, and then I
think it is quite evident that, and this is also stated in the guideline, the British guideline for prevention and management of anastomotic leakage. And again, I'm not a colorectal surgeon, so I'm just collaborating and do part of these surgeries. That also from my experience, the problems we had showed that a patient with low anastomosis, especially below 6 centimeters, will very likely have a stoma in our unit. And the reason is that it is more likely that there will be a leak. And if there is a leak, it will get clinically apparent if there is no stoma. So in simple words, a protective ileostomy may reduce the likelihood of clinical relevant septic complications, peritonitis. And this is a good reason to perform a stoma or to apply a stoma. And it may not decrease the likelihood of the leak, but the leak may be clinically irrelevant. You may be able to sit it out or close it, but without peritonitis, without ICU, with a less septic, lower septic morbidity. That's the surgeon's argument for protective ileostomies.
Yes, I completely agree. So we published recently a paper in Human Reproduction, which is an open access, and we had 44, I think, 45 fistula. 2/3 of them were rectovaginal and 1/3 leakage. And in my opinion now is that performing stoma to prevent a rectovaginal fistula is not a realistic goal. So you may prevent, maybe you may avoid the stoma, the rectovaginal fistula to be too large because there are not stools going through the stoma, through the fistula. But we did not see a difference between the rate of stoma in Rouen and rate of stoma in Bordeaux, and we have just submitted such paper in Journal of Minimal Invasive Gynecology. That's why I am about to start a randomized trial, stoma versus no stoma in rectovaginal endometriosis in patients with opening of the rectum and the vagina. And I had submitted it for a grant, so it is ongoing. The evaluation is ongoing. But I choose a randomization rate 1 to 3. So 1 patient with stoma versus 3 patients, 3 controls without stoma, in order to keep a stoma rate of about 25%, which is closer to our experience, you know. But
you would also adjust it for the height, would you?
For the height, yeah, of course.
They would all be, say, below 8 centimeters.
Yeah, we observed in our series, we observed that below 8 centimeters, the risk of fistula is 3-fold higher. than above 8 centimeter. But in my experience, I had also fistula and leakages at 12 centimeter, 15. I don't know why, but
but rarer.
Yeah,
it's rarer.
Yeah. So another question. Yeah. Do you believe in nerve sparing surgery to prevent bowel and urinary complication?
What is meant by bowel and urinary complication?
I think it is dysfunction. Bladder dysfunction and
yes, of course. In my opinion, I think there is a difference in how segmental resections are performed. I think they make a difference whether you spare nerves, whether you spare nerves plus vessels, which means the infrarectal, plus fatty tissue. But I've not been able to show the proof. I think that it may decrease the morbidity if you limit the segmental resection to the area of infiltration, if this is possible, and spare all extraluminal tissues, if technical possible. But again, there is no proof and the evidence is scarce.
Yeah, but I think that the problem is not preferring or not preferring to do nerve sparing, because of course it is better not to cut the nerve than to cut them. The problem is the feasibility. And I was thinking about this when I saw that the results of the endo-randomized trial, where there was not obvious difference in functional outcomes between patients managed with by colorectal resection in patients where the rectal shape was conservated. And I think that the difference is did not exist because patients with rectal endometriosis, with big rectal endometriosis, also have infiltration of the parametrium. So you may keep the rectal shape, but if you denervate them, because you have to remove the endometriosis, of course, you do not have a bowel which function is conservated, is normal. So I think that the problem is what to do. In my opinion, the problem is what to do with patients with bilateral infiltration of parametria. So because if the parametria is not infiltrated, of course, we perform the nerve sparing. If one parametrium is infiltrated, we remove it and we keep the nerve of the other side. But when both parametria are infiltrated, I would like to see someone performing splanchnic nerve sparing when you have a big infiltration of the parametrium. So I think it is not possible.
It's not possible.
It's not possible.
It's not possible. And I think in these cases, I would suggest less is more.
Yes.
Bilateral radical surgery for the sake of pseudo R0 resection may cause irreversible harm.
Yes. Sure. I completely agree. The other question is, when you perform segmental resection and hysterectomy, so you open the vagina, what kind of suture do you recommend? If you do a omentoplasty, and if you suture the peritoneum if you cover the vaginal suture by peritoneum?
It's a good question. Not routinely, but our colorectal surgeon, who is in our setting, basically the stapling and firing is done by the colorectal surgeon, and the preparation is done by the gynecologist. And if there is sufficient omental fat, we tend to use omentoplasties, although the evidence is sparse, in patients with concomitant low sutures, either if it's for vaginal endometriosis and preservation of the uterus, or if it's for hysterectomies. So yes, if it's technical feasible, and if the suture lines are low, we once in a while do it, but we don't have a strict standard, to be honest. It's always an issue of discussion, and it's a very focused team with 2 colorectal surgeons who we're doing the cases with. But there is no suture as such I would promote. I think it doesn't make a difference what kind of suture you use, if it's V-lock or Vicryl or whatever. I think that doesn't make a difference. In my point of view, I don't know.
Now, I agree with you. And now, Jörg Kekstein asked us to make a comment about the tension of the anastomosis, which is a very, very, very big concern. If your anastomosis is under tension, what are you doing? And the place of if you cut the inferior mesenteric artery to decrease the tension, and what is the place if you have a place for the ECG, if you use the ECG,
yeah,
and in which way you use the ECG, meaning that if you have the unsatisfactory ICG, do you repeat the resection? Do you remove the anastomosis to perform another one?
So I think that's a good question. Nerve vessel sparing sounds nice, but it's sometimes not feasible. It's not reality. And in our interdisciplinary team, the first and foremost rule is no tension. If there is tension, it's a problem. And we don't end the surgery with anastomosis under tension. If it's necessary to cut the inferior mesenteric artery, it's going to be cut. If it's necessary to mobilize the left flexure, it's going to be mobilized. But tension has to be avoided. It's the utmost principle. Sometimes you will increase tension by doing end-to-end anastomosis, and you will decrease tension by end-to-side anastomosis.
Yes, right.
So sometimes our colorectal surgeon tends to do end-to-side anastomosis because even if the anastomotic line is not low, the end-to-end will be under tension because the inferior mesenteric is stretched. Then we would do end-to-side, but if the tension is not reduced, it would be cut. Again, tension is a killer.
Yes, right. I remember very well 2 patients in my experience where there was a discussion at the end. Is it a tension? It is not a tension. No, we reduced the Trendelenburg. No, finally it's not a tension. And both of them had a fistula. I cannot say that it is related to this, but I think that if you discuss about, if you ask yourself if there is a tension, probably it is.
Yeah. So I think that would be a good how should I say thing to end the session, saying that at the time you think of tension, there is tension.
Yeah. Yes. Yeah, I think. And ICG, do you use it?
Yes, we started to, but to be honest, it never led to a change. So basically, that I remember one page. We started it recently in 2 or 3 cases, but it's not on a regular basis. And I think tension and change of color is a sign for a problem with an anastomotic line. That's what our colorectal surgeons say. And if there is a problem, if there is a change in color, if it's slightly livid, we have even had a couple of women where we just applied the whole thing again.
Yeah.
And I think it's not about, if some people think ECG is fine, yes, but we're not, my experience is very low, or the colorectal surgeon experience. It's all about, I think, tension and color.
Yes. I think there are, I saw 2 or 3 large study in colorectal surgery with ICG, and I think one of them comes from Italy, and there were fistula. They compared patients treated with ICG and patients treated without ICG. There were fistula in both arms, and in patients with ICG, there was a redo anastomosis in some patients, and they never had fistula. However, there were over one where the ICG was satisfactory and they had fistula. So I think the fistula is something, is so multifactorial that it's somehow impossible to find a way to completely avoid, because you cannot control all the factors involved in the fistula. Dan Martin from USA, so everybody knows him. Say, do you want a question on the failure to recognize potentially palpable endometriosis as potential complication of total laparoscopic surgery? So the question is the failure to recognize palpable 2 millimeter large nodules at laparoscopy is a potential complication of laparoscopy in laparoscopy compared to laparotomy? So to be more clear, we have just published a paper in Human Reproduction.
I think that should be answered by you.
Yeah. So last year, 2 years ago, Dan asked me, have you seen that from while to while you find small, very small nodules? You do not see them in laparoscopy, but you can palpate them in laparotomy. So we started to perform a study here in Bordeaux under his supervision. And in 50 patients, I found patients only with colorectal endometriosis in order to colorectal resection in order to palpate. So we found small nodules not seen in laparoscopy in 25% of cases, meaning that if you perform a disc excision or a shaving inside in laparoscopy, maybe in 20% of cases, you leave some small nodules, very small nodules, 1-2 millimeters, but you can palpate them. And in one case, now I see better right now after this study, and I saw that one on this nodule was taken into the stapled line for a disc excision, meaning that we removed the big nodule by disc excision, but when the stapler closed, there was another small satellite nodules, and we saw very well the relief when the stapler closed. So then I see another one, and we carried out, we finished by carrying out a segmental resection. So do you think that this concern of small nodules that may be involved in the stapled line in laparoscopy may increase the risk, may have a consequence on complications and on fistula when compared to laparotomy?
I think we've also made this observation, and I think the number of 25% is probably really hits reality. The question A is, are these left behind lesions clinically relevant? We don't know.
Yeah.
So that should be stated. The second question is, may it cause a problem if it gets into the stapling line? And I would say yes. I had one case where we actually performed, let me answer the question the other way around. It may be a problem because we also do transanal discs where we invert the nodule into the opened magazine. And especially I remember 2 patients where we didn't fully manage to invaginate the nodule. And then the anastomosis just broke up. intraoperatively because the clamps didn't really bite into healthy muscular tissue.
Yes.
And that, of course, raises the thought that if you perform a connection between two tissues, luminal tissues, with the fibrotic area, the microperfusion is less valuable. The leakage rate will be higher. So I think it is a critical issue not only in segmental resections, but also in discrete resections or transanal discrete resections to be in healthy tissue applying the stapling anvils.
Mm. Yeah, I fully agree. We have a question from Ahmed. He said, is the long-term improvement of symptoms after treatment of rectovaginal endometriosis worth the risk of sequela and possible complications of bowel resection? In my opinion, the answer is definitively yes. What is your answer?
Well, I think there's been a very interesting paper by the Aarhus group, by Anne Engelquist and Mikkel Hansen, and you know them very well, Horace, who looked at the percentage of patients who can be managed expectantly. And the majority of patients will be or can be managed expectantly, up to 70%. So I, I'm able to say that I think I also probably do surgeries only on a third of the women I see with deep endometriotic nodules, because only the minority of them does have problems that are absolutely resistant to medical treatment options. But we do have, I think, a good third that is really, really impaired by the pain, impaired quality of life, fertility issues, etc., etc., etc. And if these patients are treated adequately based on a proper preoperative workup, I think you will do good.
Yeah, but no, I think that the questions, I understand the questions a bit differently. I think he want to ask if you perform the surgery of colorectal endometriosis and you take the risk of complication, if at long term it works, meaning that if you do not have the surprise to see that you perform the surgery, the patient had the risk of complication, and then 3 years she's back with the same pain.
I agree. Well, I think the question that arises is, what is recurrence and what is persistence? And I think that we do see a lot of patients who have undergone X amount of previous surgeries who have not been radically treated. I'm not saying that you have to treat every patient by radical surgery, but if you decide to treat deep endometriosis surgically, in my opinion, and I think the body of evidence is fairly good, to do it radically. Of course, bearing in mind fertility and nerve function. I suspect that a very large percentage of patients does not have recurrence. They do have persistence. And even in the patients who are radically treated, of course, yes, you will have patients with recurrent pain issues and problems. But there are very sparse, good long-term data, 3 years plus. My personal impression is that the majority of the patients will do fine. They will not be pain-free, but they will stay on a level of pain, even even the ones that do have recurrent pain, where they are able to manage the problem and are far away from the debilitating, quality of life reducing pain problems.
Yes, you're right. So I just added on the chat 2 studies with a follow-up 4 and 5 years after the surgery in randomized trial, Endor. So there is no woman, no patient lost of follow-up, and you can see that all the patients are improved, and the improvement is constant until 5 years. And now I'm preparing 7 years follow-up, the paper. And 80% of them had the pregnancy. 80% of those who intended to get pregnant were pregnant, majority of them naturally. So the surgery for endometriosis, for colorectal endometriosis works, even though we have a risk of 3% of complications. But even though they have a complications such as rectovaginal fistula, we can manage it during 1 year, at least 3 months and until 1 year. So I think in patients who are symptomatic, it works, and there is no justification to postpone them, because if you postpone them, because it's too risky, you're too young. 5 years later, the disease will be much more severe and the risk will increase like this. So I think that once the patient is symptomatic and once the medical treatment does not work, there is not hesitation to perform the surgery, even though the patient is young, because the younger is the patient, the more aggressive is the disease.
Yeah.
Do we have another question? Yeah, Ludovica said, Ludovica from Brussels asked if, in your experience, do you think that inserting a double G catheter in the ureters preventively in very lateral rectovaginal nodules is useful to prevent ureteral injury? So do you use systematic large use of GG stent preoperatively?
Only in cases with pre-existing obstruction.
Yeah, me too.
I think it's the other way around. Me personally, I think it's a lot more difficult to dissect the ureter with a stent inside.
Sure.
I would only use the stent in pre-surgically verified hydronephrosis, otherwise never. The dissection as such, in my personal experience, is easier without a stent. And you could still put a stent inside if you get a leak or do harm or have a injury of the ureter. You could still do that fine.
Yeah, I completely agree. And the longer the time of the stent preoperatively, the more difficult will be the surgery. So I remember that tomorrow I will carry out a patient surgery in a patient with hydronephrosis and sacral roots involvement, but the diagnosis was put 1 year ago, but as she had corticotherapy for another disease, autoimmune disease, we could not perform the surgery because the corticotherapy was a high dose and the risk of complication was too high. So now I have 1 year GG stent, and I think that the dissection of the ureter will be terrible. 1 year GG stent induces such inflammation that it is very, very difficult to carry it out. Okay, so do you hear me?
Yeah.
So I think we finished the questions. So I think it was very, very interesting, your presentation, and I was sure that we have a lot of things to learn this evening. It was a great pleasure to exchange with you, because we have not seen each other since 2019, before the COVID. And please pay attention to our webinar program, because we have a very very experienced speakers, and we are always very, very pleased to exchange with colleagues from Peru, from Trinidad Tobago, from Israel, from worldwide. So thank you very much. Thank you very much, Gernot. It was excellent, your presentation.
Thank you.
Thank you, everybody. And I say hello to Dan, because he has a huge experience in endometriosis. He started the surgery of endometriosis in 80. And however, he spent a lot of time with us to share with us. So thank you very much. And I hope to see you all of you in December in Bordeaux at the 6th European Endometriosis Congress. So thank you very much, and have a nice evening.
Thank you, Horace.